Good afternoon. Assalamu alaikum. My name is Ravi Mamtani. I work for Cornell in Qatar, where I'm a professor and the vice dean for population health and lifestyle medicine. So I want to take a moment to welcome you, a warm welcome to all of you, and on yet another exciting webinar this afternoon. You will recall that we do this by way of population health and well-being series, the objectives of which are one, discuss contemporary and critical topics relevant to healthcare, medicine, and population health. Number two, examine evidence-based practices germane to public health and patient care. And number three, describe opportunities and challenges in the evolving phase of healthcare and population health. Some housekeeping notes before I introduce our esteemed speaker this afternoon. Your cameras and microphones are turned off. Use the Q&A feature to type questions and or comments that you may wish to make. And questions will be addressed at the end of the session. And I will request my colleague, Dr. Suhaila Chima, who's an assistant dean at the Institute for Population Health, to basically moderate that session. So this activity is accredited both by the Accreditation Council for Continuing Medical Education in the US and also by continuing professional development by the Department of Healthcare of the Ministry of Public Health. So just a couple of words on evaluation certificates. The post-activity evaluation will be available in your Cloud CME by May the 12th, 2021, of course. You will receive an email notification once the evaluation is available in your Cloud CME account. And your certificates will be available for download once you complete the post-activity evaluation on the Cloud CME portal. So with those housekeeping notes in place, it is now my pleasure and an honor to introduce dear colleague and a great friend, Dr. Adeel Butt. And if I had to read his entire CV and bio sketch, it would take me a lot of time. So I'm going to abbreviate that. And I think that abbreviation will give you a flavor of Dr. Butt's excellence in the field of medical sciences and the work that he has done in the past 25 years or so. Professor Adeel Butt's work, education, and training experience spanned several countries over 5 continents, listed among the world top 2% scientists in the prestigious Stanford list. Professor Butt is also a Fulbright Scholar, Yale Johnson Scholar in International Health, recipient of the US NIH Career Development Award, Hamad Medical Corporation Qatar Excellence in Health Services Research Award, Pakistan Society of Hepatology's Distinguished Academician Award, and recipient of other innumerable national and international awards. Professor Butt has lectured extensively around the world as a visiting professor, having delivered over 500 invited lectures and consulted with governmental and NGOs and academic institutions in building research, educational, and training capacity. Over the past 20 years, Professor Butt has held numerous senior academic positions, including, I'll just name a few, clinical directorship, residency program director, division chief, department chair, Institute Director and Corporate Chief Quality Officer, just to name a few, as I said. Needless to say, he has published extensively, and I think the number of papers that he has published is over 190, and these are in high impact journals, presented over 170 abstracts at major international conferences and meetings, and has mentored numerous young physicians and researchers who now hold key positions in academia in the US and elsewhere in the world. So with those brief remarks, may I now invite Dr. Adeel Butt Adeel, the screen is yours, and welcome.
Thank you, Dr. Mamtani. That is a very generous and kind introduction. But first of all, let me thank Institution for Population Health and Weill, Cornell, Qatar for inviting me, and a special thank you to Dr. Mamtani and Dr. Chima, who have spearheaded this institute and taken it to such wonderful heights. I'm honored to be the speaker today. I've done one talk for them before, which was very well received and very well attended. So it's my honor once again to be a speaker. These are my funding over the years, but I have no relevant financial relationship to disclose for the talk that I'm going to deliver today. I will not be discussing any unlabeled or unapproved use of drugs or products. Basically, my talk is divided into three parts today. First of all, I would like to start with the concept of big data in healthcare, how it relates to healthcare in terms of definitions, the types of data available in healthcare, types of big data available in healthcare, and how we curate those data and use that. Then I would go on to give you two examples of how I've used big data in healthcare in my career. The first one being the story of hepatitis C virus infection, how we rewrote the natural history, clinical outcomes, and comparative effectiveness of various treatments for hep C over the last nearly quarter century or so. And then we'll bring the story closer to home and talk about how we've used big data for fighting a global pandemic, both in Qatar and internationally. So let me set the stage up for the talk by creating a scenario which all of us clinicians will be all too familiar with. A patient walks into our office, and such a patient would have many questions when he or she walks in. They want to know what their diagnosis is. They want to know what the treatment options are. And if there are more than one treatment option, which one is the better or the best option that can be used for them? And if you treat them, what are the chances of improvement? Or even more importantly, what is the chances of curing whatever they've come with? What are the benefits and harms of treatment? And equally important, what are the consequences if he or she does not get treated for whatever reason if they decide not to get the treatment? As a physician or a healthcare provider, you also have questions at a different level, at a higher level. You want to know, is the treatment that you're going to prescribe effective and safe in the real world setting? You've amassed a wealth of knowledge from clinical trials and high-level research, but now you're in the real world with the real patient in front of you. You want to know if those data or information translates to this particular person sitting in front of you in the real world. Is the treatment that you're going to prescribe cost effective? And is the benefit of treatment more than the cost incurred in whatever terms you may want to measure that? What is the societal impact of treating a patient or not treating a patient for any particular condition or so? And how do we answer these questions? Well, we answer them by generating new knowledge and using evidence-based research on sound science. In other words, we want to do good research that would generate this kind of evidence for us. This research could be preclinical research in the lab, or what we call omics, proteomics, genomics, and so on and so forth. It could be animal-based research, or it could be clinical research, phase 2, 3, 4 clinical trials, or population-based research. And all of these have several subtypes under them. But one common core element of all types of research is gathering of accurate, verifiable, and reproducible data. Now, with the explosion in knowledge and ability to create and analyze massive databases for numerous purposes, we need to be particularly aware of the capabilities and, even more importantly, the limitations of the data that we use. To be able to help our patients, which in my mind is the most important and fundamental reason for doing clinical research, these data need to be converted into useful information. And the useful information then needs to be translated into actionable intelligence. Now, with all those explosions in knowledge that I briefly mentioned, the term of big data has been used in the last several years or so. So while the actual term is relatively new, the act of gathering and sorting large amounts of data for various purposes is ages old. Now, the big data concept gained more momentum in the early 2000s when an industry analyst named Doug Laney articulated what is now the mainstream definition of big data. And he used 3 V's to define big data: volume, velocity, and variety. Volume refers to the fact that organizations collect data from a variety of sources, and these are very, very large amounts or volumes of data, including business transactions, social media data, information from sensors, or machine-to-machine data. In the past, it would have been very difficult to store these data because of the volume, but now we have capabilities of storing tremendous amounts and volumes of data relatively easily. The second V is the velocity, which refers to the fact that data streams at an unprecedented speed, and it must be dealt with in a timely manner. Things like RFID tags, sensors, smart metering devices, they drive the need to deal with torrents of data in near real time. The third V, or variety, it refers to the fact that data comes in all types of formats. It could be structured numeric data, like in traditional databases, or it could be unstructured text documents, emails, videos, audios, stock ticker data, and financial transaction data. And all these types of data, which constitute a large variety of sources and types, needs to be fed into some sort of an analyzable format. Variability refers to the fact that, the fourth V has recently been added, which is variability. And variability refers to the fact that data does not come at a uniform speed from whichever sources you're gathering. In other words, there are data flows which can have very high peaks, meaning large amounts of data coming in 1 second, and that ebbing in the next minute or two, or hour or two, and so forth. Daily, seasonal, and event-triggered peak data loads can be challenging to manage. And if those data are unstructured, then it's even more difficult to do that. So that is a variability that one has to deal with. One thing that underpins all these V's or all these types of big data is the fact that there's tremendous amount of complexity to these data. As I mentioned, these data come from multiple sources, which makes it difficult to link, match, clean, transform across data systems, because we have to do all that to make sense of this data. And as I mentioned in the previous slide, to turn it into information and ultimately actionable intelligence. Now let's move on to sources of data in healthcare, because that is what the topic of conversation today is. Now, traditionally, we have thought of big data in healthcare as genomic sequencing data. But more recently, there are many other sources which constitute big data in healthcare. These include electronic health records, medical imaging data, payer records, and medical devices and wearables. And all these types of data sources contribute to the overall big data in healthcare. And they all meet the definition that we mentioned in the last slide, that is the 4 V's of velocity, volume, variety, and variability. Like with any other thing, there are some advantages and there are some challenges that we need to be acutely aware of. For big data, the advantages include that you can do instant analysis of very large amounts of data, and you can actually do real-time gap analysis. You can devise instantly new strategies, and then you can deploy them to your advantage or to your industry's or organization's advantage. Industry trends can be identified immediately, and there is a fair amount of efficiency in tracking and monitoring using big data sources. What is also very advantageous is that because of the volume and the longitudinal nature of these data, rare events and issues can be identified relatively quickly and easily. We also have to be keenly aware of challenges with real-time big data analytics. Of course, there is a huge cost and effort associated with setting up these types of data sources. Enormous amount of computing power is required to set those up, and that costs a lot of money. There is a fear of missing the forest for the trees, meaning you have so much data that you can lose some of the nuances of the data. The trends can reverse very, very quickly. What is a very hot trending topic on social media 1 minute can totally be off the next minute or in the next hour or the next day. So there is an efficiency versus efficacy trade-off that people also mention when dealing with these, that while you gain efficiency, is it really worthwhile to look at all those data when they change so rapidly? And there is a fear of information or intervention overload. If you intervene too early, when a trend has just set in and the trend reverses in the next short period of time, but you've already instituted some intervention based on the trend, you could actually have inadvertently caused harm to your organization. Now let's move to the two stories that I talked about, and I'll take you back about 20 to 22 years or so when I started my career in hepatitis C. At that time, when I was looking into a topic for my long-term career progression and research that I needed to conduct, I found that there are a lot of unanswered questions in the Hep C story. We had tremendous gaps in natural history of Hep C, the treatment cascade, effectiveness of various regimens in real-world setting, and particularly consequences of Hep C in the real-world settings. So questions which are very easy to answer today and are at the tip of our tongue to answer, things like how many people are eligible for treatment, how many initiate treatment, how many complete treatment, etc., were actually completely unknown at that period in time. So that is how I started looking into these. And since this was a large pandemic, even back in 2001, and the natural history, as we knew it at that time, was a very slowly progressive disease over 2 to 3 decades or so, we needed very large data sets to answer these questions so that we could pick up uncommon occurrences, uncommon events of interest, and we could follow patients for a very long period of time. So I decided to work with the Department of Veterans Affairs and National Healthcare Data System. Now, those of you who are not familiar with the US VA system or the Veterans Affairs system, this is a large integrated healthcare network across all of the United States, which takes care of all military veterans. In other words, people who have retired from the military and now need healthcare. The good thing about the VA healthcare system is that it is all connected by a single medical record system. The downside was that at least at that time, the data that we needed for our analysis were housed in different servers in different states in different formats. So I created the world's largest database of Hep C infected people, which I called archives, or electronically retrieved cohort of Hep C infected veterans using multiple data sources that I've listed out here. And I've also listed the types of data I gleaned from or gathered from those individual data sources. For example, National Patient Care Database included demographics, diagnoses, utilization, and vital signs data that I pulled out. But mortality data was not in that database. For that, I went to a different data set. Labs were in yet another data set, and I had to put all those data sets out and combine them into a single data set and then clean that for analysis. This gives you just an overview or a picture of the complexity of setting up and retrieving these kind of data from an enterprise data warehouse. Now, why did I choose the VA and what are the benefits of the VA database? It is the largest integrated healthcare system in the US. There are 22 million veterans living in the US at this point in time. Of those, 9 million are enrolled in the Veterans Health Administration or the VA system, and 6 million of them are seen every year. 6 million unique patients have at least one encounter at one of the 150 plus hospitals and nearly 900 community-based outpatient centers. So that gives you a flavor of how massive this system is and the amounts of data that the system generates. When we started, we identified only about 120,000 Hep C infected people in the first wave back in 2002-2003 timeframe. And over the years, I've regularly updated these data. And now we have more than 400,000 Hep C infected people and more than 400,000 Hep C uninfected demographically and clinically matched controls. This makes it the world's largest database of Hep C infected people and controls, and has resulted in numerous publications that I'm going to share with you over the next few slides. Now, what is the process of gathering and analyzing these data from such a large system? Of course, we have all the regulatory approvals already in place. We start with the study idea. We do a quick feasibility survey to see if we have enough outcomes of interest or enough patient population that is of interest to us. We write data specification sheets to and write exact data parameters. Then we give that to my computer programmer who writes a computer program and runs it on this large, very, very super fast mainframe. And for most of our data sets, this program runs for 3, 4, or 5 weeks for data to come down. So you can imagine the amount of data that has to go through. Trillions and trillions of data points have to be analyzed to retrieve the data that I'm looking for. So I've had these programs run for up to 2 months, continuously, 24 hours a day, to get me the data set that I need. Once we get those raw data, we merge all the parameters into a single data set and we start cleaning it. And after cleaning, then we start analyzing and trying to answer the question that we started off with. This cleaning process is a massive process which requires a lot of time and effort and sitting through to do that. So let me take you through some of the questions that we answered through this data set. And this is just a very small flavor of numerous questions that we have answered from this data set. So my first question was in 2003, how many people who have Hep C have ever been initiated on treatment? And to your left, you can see that prior to 2003, we found that less than 12% of patients with Hep C monoinfection ever initiated treatment for Hep C. Now, for a disease that has significant consequences, that is obviously a very, very small number. Now, over 2 decades after 2003 till now, the treatment landscape has changed considerably. And we repeated this study in 2017 after the approval and advent of the newer antiviral therapies for Hep C, the all-oral directly acting antiviral agents. And in 2017, we showed that more than 50% of Hep C infected people were now being initiated on treatment. And that number has actually gone even higher from that now. For Hep C HIV co-infected people, the number in 2003 was only 8% or so. And again, it's more than 50% in more recent times. The next obvious question was that who completes the full course of treatment? And in the earlier years, in the 2003, 4, 5, 6 time frame, when we only had pegylated interferon and ribavirin-based treatments, it turned out that only about 25 or 1/4 of the patients who started treatment ever completed a full course of treatment. And that was related to the difficulty of administering interferon and ribavirin and the side effects associated with that. And more recently, we have shown in an elegant series of studies that this number has gone up dramatically. You can see that on the right-hand side of your screen, from 20% with interferon ribavirin to 26% with PEG-RIBA, and with the all-oral regimen, now it's close to 90% of people who complete a full course of treatment. So that was a dramatic shift. And these kind of data are critically important for policymakers and payers and those who are setting up services for various diseases. Because those treatments were very, very expensive, when they were instituted, people started rationing those treatments out. And the big question was, who should be treated first? So we did another elegant series of studies to determine what would be the criteria for shortlisting patients for early treatment. And we wanted to see who would get the greatest benefits in terms of mortality, hepatic decompensation, and liver cancer. And we showed that if we use non-invasive markers of disease, FIB4 is the best marker to predict who would benefit most for treatment. A FIB4 cutoff of 2 was an optimal cutoff for initiating treatment for mortality reduction. And a score of 3 was an optimal cutoff for initiating treatment for hepatic decompensation and hepatocellular carcinoma reduction. This again was an important piece of information for policymakers, payers, and clinicians. Now the treatments are more readily available and it's not that critical because everyone needs to be treated and should be treated as soon as possible. Now, randomized clinical trials are always the gold standard for determining efficacy of treatment. But a lot of times, randomized clinical trials don't translate into what we see in the real world. So we wanted to see that are those treatments which are highly effective in RCTs, the new all-oral antiviral agents for Hep C, are they equally effective in real life? And again, we did a series of studies and we demonstrated that sustained virologic response rates, which is the equivalent of Hep C cure, they're consistent in the 90 to 95% range with the newer regimens, all-oral regimens. And this is almost exactly the same as what we were seeing in clinical trials. And this was very, very different than what we saw for interferon-based regimens early on, as I will show in a slide later on. Now, this high level of cure with new regimens in real life was even true for traditionally difficult to treat populations. For example, those who have cirrhosis at baseline and those who have chronic kidney disease, for example. And we looked at all those populations separately as well. One example is given here of patients with chronic kidney disease. With interferon ribavirin-based regimens, ribavirin was relatively contraindicated in patients with CKD, but it could be given with close monitoring, but response rates were very low. With these new regimens, we showed that not only treatment is initiated in a large number of people with CKD, including CKD stage 4 and 5, but the response rates are almost similar to those without CKD in the 90+% range. This was another major advance in the treatment of Hep C. I did mention the difference between clinical trials versus the real world. And this is kind of a temporal graph of showing the difference between real world and clinical trials. On your left-hand side out here, where I show interferon ribavirin for 48 weeks, 13% had clinical cure in the real world versus 41% in clinical trials. Now, all these red graphs are studies done by my group and my team through archives, except this first one for interferon ribavirin, which was done by another colleague. And we showed that this gap between clinical trials, which is the blue bar, and the real world results, which are the red bar, began to narrow with the newer regimens. And with the new DAAs, which are all oral regimens, the results are identical. Another question that we asked was, what is disease progression, Hep C disease progression with and without treatment? And we showed that people who get treated for Hep C have a dramatic survival advantage. We showed that even in the interferon ribavirin era, and then we replicated that in the DAA or direct acting antiviral agent-based regimen era. On your left-hand side is the interferon ribavirin era results, and on your right-hand side are the DAA era results. Now, the take-home message from this was that treatment significantly reduces mortality. Even when you don't complete a full course of treatment with interferon ribavirin-based regimens, we saw improvements or reduction in mortality. And with the new DAA regimens, the results are quite dramatic in terms of mortality reduction. One of the drawbacks of studying Hep C natural history and disease progression have been the difficulty in identifying the exact time of infection. In other words, when we diagnose Hep C, most people have already had Hep C for several years. So as you can appreciate, that to determine disease progression in natural history, you need to know your time zero or the exact time when the people were infected. And that was often very difficult to find. Since we had these big data, hundreds of thousands of patients of data over 2 decades, we could identify a large number of people who had a negative hepatitis C antibody to start off, and a subsequent Hep C antibody which was positive. So this gave us a very clear indication of when they actually seroconverted or when they contracted Hep C. So we created the world's largest seroconversion cohort. First cohort was created back in 2014-15 of about close to 2,000 people. And we showed that disease progresses pretty rapidly in the first few years. So on your left-hand side, you can see that cirrhosis, incidence of cirrhosis increases within the first 3, 4, 5 years and plateaus at around 8 to 9 years or so. So this was not known before. Our understanding was that cirrhosis occurs about 20 to 23 years after diagnosis of Hep C. And that was because of the limitations that we have with identifying the exact time of infection. So we kind of turned the paradigm upside down a little bit. And again, this is the time from seroconversion to first event of cirrhosis or hepatic decompensation. And we can see that those who are Hep C positive have a significantly shorter time to development of these two outcomes. We repeated the seroconversion cohort study more recently, and actually this paper was published literally 2 months ago. Now we have about 12 to 13,000 people who we know their seroconversion date, and we followed them for a period of about average of 9 years or so. And we can see that there is a difference in cirrhosis over a period of time, but the difference in mortality is dramatic. Those who were untreated and those who were treated with virological cure. So if you're untreated at the end of 10 years, about 35% of those people have died. But if you treated them, these are Hep C people with cirrhosis, only about 5% of those people have died over a 10 to 12 year period. Now, this difference is also quite marked in terms of hepatic decompensation, but in the 10-year time frame, because hepatocellular carcinoma is a relatively rare event, we did not find a statistically significant difference in that event. I'll skip this in the interest of time. Now, talking about beyond the liver, we were one of the first people to show nearly 12 years ago the link between Hep C and coronary artery disease. In a very large cohort of patients, nearly 175,000 people, we showed that Hep C is associated with a nearly 30% increase in the risk of coronary artery disease. And this is independent of other coronary disease risk factors. And more recently, we showed that if you treat these people for Hep C and you achieve virological cure, you can actually reduce the incidence of cardiovascular disease events. For CVD events, we showed that there is a difference between treated and untreated. Overall, there's about a 1/3 reduction in mortality from 30 to 20% or so. But when you break it down by regimen and attainment of a virological cure, it turns out the regimen is more important in reducing the incidence of CVD events than achievement of virological cure. When we repeated these studies for diabetes, which is another area of interest that we had, we again demonstrated that there's a significant reduction in incidence of diabetes after treatment, but here virological cure is more important than the type of regimen that you use. So for both cardiovascular disease and for diabetes, we showed a significant reduction in incidence of events. And we've shown that for a couple of other diseases as well, which we will not go today because of the shortage of time. When the new DAAs came to market, there was a concern about their effect on renal function. People started seeing some decline in renal function, and they also started seeing increased risk of hepatocellular carcinoma with these. And we, again, led and published landmark studies which allayed those fears. We showed that decline in renal function, while there, is of relatively little clinical consequence and does not happen much more rapidly than comparable other populations. And we also showed that for hepatocellular carcinoma that actually DAAs do not increase the risk of HCC, but actually decrease the risk of hepatocellular carcinoma. I talked about overall mortality, but one always wonders if the liver-related mortality is actually decreased by treating Hep C, because Hep C is primarily a virus that affects the liver. And again, in these landmark studies, we showed that liver-related mortality is dramatically reduced when you treat the patients for Hep C. So those are just a few studies, and I've listed several other studies, some other studies on this slide that and some of the questions that we answered. We showed that statin use is associated with a lower fibrosis progression and a reduced rate of risk of hepatocellular carcinoma. We showed an association between proton pump inhibitors and cirrhosis, tricyclic antidepressants, and cirrhosis, and so on and so forth. So the lessons that we learned from an analysis of these big data for Hep C is that newer DA regimens are at least as effective in the real world as they are in clinical trials, and that was a major advancement in our knowledge. Another major advancement in knowledge was the benefit of treatment is apparent very early on, within the first 12 to 18 months of treatment. Therefore, deferring treatment is not an option. Complications also appear very early after HCV infection. When you look at the population as a whole, therefore, again, deferring treatment is not an option. And benefits go way beyond the liver. You get benefits in terms of reduction in cardiovascular disease events, certain cancers, both hepatic and non-hepatic cancers, diabetes, etc. So again, deferring treatment is not an option. So this is the impact of archive, and actually the number of publications is even more now. Just from this data set, we have published close to 50 studies with a cumulative impact factor of close to 350. There have been 7 Young Investigator Awards that my mentees have been awarded from studies done primarily through archives. And we changed this paradigm, which I'm not going to go into much detail, except to show that now, when I started doing Hep C research, for every 100 people with Hep C infection, you could expect cure in about 1 to 2% of people. About 3 years ago, when I redid this model, now we can expect cure in about 32 to 35 people out of 100, and this number is going to go up as we refine treatments even more. Moving on to the other story, which is closer to home, how did we fight SARS-CoV-2 pandemic using big data? So we saw our first case of SARS-CoV-2 infection in Qatar on February 27, 2020. And soon thereafter, we started seeing a tremendous decline in number of people who were sent to the hospital with any condition. So we wanted to understand the dynamics of pathways of care. So the first study that I did with my team was looking at the overall number of hospital admissions, how they changed from previous year to this year after we started seeing patients with SARS-CoV-2 infection. So if we look at Hamad General Hospital, we found an year-upon-year decline of about 10% in total admissions and about a 50% decline in elective surgeries. Of course, this was partly because we stopped elective surgeries as well. Same was true for Heart Hospital, that total admissions went down by about 50% and elective surgeries went down by 54%. The Cancer Center is a much smaller hospital with less number of beds and patients, so it is difficult to identify or be certain about the trends, but we did see a decline there. In Women's Hospital, we saw the decline in total admissions by about 21% and same amount of reduction in elective surgeries. Now, these are overall admissions. Now, we also wanted to look at specific acute care conditions, which we thought generally patients must come to the hospital if they have those conditions for optimal outcomes. And these include appendicitis, acute coronary syndrome, stroke, fractures, cancer, and so forth. And we still saw a 20 to 80% reduction in admissions for those conditions. So which was quite concerning for us. The only thing that we saw in the other direction was respiratory tract infections, which actually increased in terms of admissions. And a fair number of those are, of course, related to SARS-CoV-2 infection itself. So that was overall admissions to the hospital. Now, we also looked at ED volumes. And year on year, we saw a 20 to 40% reduction in ED volumes at Hamad General Hospital, 30 to 90% reduction at Heart Hospital, 20 to 46% reduction in volumes presenting to Women's Hospital year on year between 2020 and 2019. Now, one could possibly think that a lot of those people who used to present to the emergency room used to be people seeking primary care for minor conditions. And now, because of the pandemic, they just stayed home and did well. Well, we actually looked at the triage acuity of everyone who came to the hospital, to the emergency department. So Canadian triage acuity score is what we use in Qatar. And triage score 1 and 2 means these people are at the highest acuity level. These are people who have critical conditions or require immediate resuscitation to survive. And even for these conditions, we saw a 55 to 68% reduction in people presenting to emergency department. We also looked at ED visits specifically for cardiac symptoms. And again, year on year, we saw 25% reduction in March and a 50% reduction in April from the year before. We also looked at those who actually had a cardiac diagnosis, for example, acute coronary syndrome or congestive heart failure. And even these diagnoses decreased by 24 to 42% or so. Now, these obviously have significant implications for healthcare policymakers and planners, because if a lot of people are not seeking care, once the pandemic is over, are we going to see a surge of these patients coming to the hospital and seeking care, and will we be overwhelmed by these patients once we get over the pandemic? Now, this is a paper that has been making a lot of waves in the last 5 days, and we are getting queries from everywhere across the world, and some politicians in North America and Canada are actually using wrong inferences from this study to score political points. This is a study published in the New England Journal of Medicine, one of the first studies from Qatar to make it to the New England Journal, published last Wednesday, literally 4 days or 5 days ago. We looked at vaccine effectiveness against variants of concern, including the B117 and B1351 variant. 117 is the UK variant, and 1351 is the South Africa variant. And we found that the the vaccine, the Pfizer vaccine that we use is highly effective against these variants. It has about 89.5% effectiveness against the UK or the B117 variant, and 75% effectiveness against the 1351 or the South Africa variant. So while effectiveness is slightly lower for this against the South African variant, it is still very, very good overall. And this is for infection alone. When we look at the serious outcomes like critical disease, severe disease, or fatal disease, vaccine is 100% protective against both the UK variant and the South Africa variant. And these data come from analysis of well over 200,000 people in Qatar that we did. So this is very reassuring data that while we have a wave of these new variants of concern, we still have vaccines which are very, very effective against preventing infection as well as preventing severe, critical, or fatal disease. The other question we get asked frequently is, does natural infection protect against reinfection? So I showed you in the previous slide that the vaccine is highly protective, but what about those people who have had natural infection? So again, this is a study led by Cornell investigators, Dr. Layth Abu-Raddad and his team, and we are a part of that. It showed that natural infection is highly protective against both the 135 variant and the 117 variant, to the tune of about 86 to 92% or so. So whether if you had a PCR positive infection, you have a 92 to 97% protection. And if you are antibody positive without ever being diagnosed with a PCR, you still have 86 to 96% protection against reinfection. Again, very, very reassuring data. Another question, again, answered by Dr. Abu-Raddad's team, and these papers are in peer review right now. Do variants of concern cause more severe disease? And Dr. Abu-Raddad's team, in combination with MOPH, Hamad, and other academic health system partners, showed that indeed this disease by the variants is a little more severe than the disease we see with the wild type virus. Now, we also looked at vaccine effectiveness in the VA healthcare system in the US. Now, the VA population is a particularly vulnerable population because they're older and they have a very high burden of comorbidities. And here I also looked at vaccine effectiveness from Moderna versus the Pfizer vaccine because we could separate those two out. And turns out that 7 or more days after the second dose, Pfizer vaccine is about 91% effective in preventing infection, and the Moderna vaccine is 95% effective in preventing infection. And others have now been showing similar data across the world. So the message is that these vaccines are highly, highly effective in preventing infection and severe disease. And this protection is present in whether you are older or younger, or whether you have a high burden of comorbidity or no comorbidities. We are also looking at breakthrough infections in very large data sets. A breakthrough infection means people who have been vaccinated and have full course of vaccination, but then develop new infection. The numbers are relatively small. In other words, the rate of breakthrough infection is very, very small, but it does happen. The outcomes are not significantly different in terms of other things. But if you have been vaccinated, compared to unvaccinated people who have this infection, breakthrough infection among vaccinated, vaccination is associated with less severe infection and lower likelihood of death or lower risk of death. So the teams in Qatar have also published or are about to publish several other papers from big data. These include herd immunity related demonstration of herd immunity, protection of various populations based on antibody positivity, infection rates in healthcare workers, mortuary and cemetery workers, which we have published. Dr. Abu-Raddad's team and Qatar University teams have done mathematical modeling of the epidemic in Qatar and how it has impacted on national response to COVID-19 and so on and so forth. Again, we have had numerous publications from big data, close to 20, and at least 8 to 10 are in peer review right now, with very high cumulative impact factor. And this also shows the power of collaboration between AHS or academic health system partners, which include Hamad, PHCC, Weill Cornell, Qatar University, HBKU, and so on and so forth. So to sum up some summary words about observational data, some strengths and opportunities include that these are ginormous data sets where you have the ability to analyze data over a long period of time with long follow-up. You can identify large number of uncommon events from geographically diverse populations. These are highly cost effective because once they've been set up, then you can just churn analysis out of those existing data sets and you can use them for multiple purposes as we've shown in this talk today. You also have to be careful about the weaknesses or challenges with these. Generally, with observational data and big data like these, you cannot make causal inferences. You can determine associations. There are a fair amount of missing data, but there are ways to address that statistically. And there are confounders and indication bias. And again, there are ways and methods to address those and minimize those concerns. There are non-standardized collection of variables, and that unfortunately is going to be there because these data are not being collected purely for research purposes, and that limitation will remain. Excuse me. So in conclusion, big data living cohorts, and the word I use for such cohorts like archives is living cohort because they keep on giving us over a long period of time. They can be exceptionally productive and are highly cost effective and cost efficient. They span the gamut of clinical research. You can do health services research, clinical outcomes research, clinical epi, comparative effectiveness, post-marketing surveillance, and so on and so forth. And these are very well suited to study infrequent outcomes and rare outcomes. I'll stop here, and I want to acknowledge a lot of people who make these things possible. Of course, Her Excellency, the Minister of Public Health, who has been the rock and support for all our teams, and the entire Ministry of Public Health team, the National COVID Study Group, and the Scientific Research and Resource Team, and the Policy Planning and Performance teams, the Business Intelligence Unit team at Hamad Medical Corporation, the Cornell Qatar ID Epidemiology Group, and all our HS partners. But most of all, numerous healthcare workers who have spent days and nights without any break for well over 1 year to take care of COVID-19 patients and also help gather critical data to help us fight this pandemic. Thank you, and back to you, Dr. Mamtani.
Thank you, Dr. Adeel Bhatt, for sharing all your experiences, the wonderful studies that your group have published, and with all the collaborators. And thank you again for sharing the data on vaccines. I think, of course, I've also been reading a lot on social media, about the study that you've been referring. It got a lot of coverage, even up to New York Times. So I think that data is very hopeful, and I would like you to just comment and, I think a lot of people are going through COVID fatigue. And people are just trying to look for some ray of hope, with all these new variants. Of course, the data that you spoke about was limited to the UK variant and to the South African variant. And now we are hearing about new variants coming in. But any last thoughts and just a message before Eid break for everybody?
First of all, Eid Mubarak to everyone, Ramadan Kareem. And I would like to thank Dr. Mamtani, you and your whole team for a wonderful opportunity. I also want to emphasize that please do get vaccinated. The vaccine hesitancy is real and it is dangerous. These vaccines have been about close to 400 to 500 million people in the world have been vaccinated with extremely, extremely, extremely rare events happening. So these are generally very, very safe vaccines. And till we get herd immunity, until we get large swaths of population vaccinated, please do practice careful social distancing and mask wearing, and follow the MOPH guidelines. We issue those guidelines after a tremendous amount of thought and work. The MOPH works very hard, and those are based on science and not just pulled out of thin air. So please do follow those.
Great. Thank you again, Dr. Adeel Bhatt, for that wonderful presentations, all your thoughts and all your shared experiences. We would like to thank all our participants who've joined us today in Ramadan. And I would like to extend warm wishes to all of you, whoever's celebrating Eid, Eid Mubarak to you all in advance. And inshallah, we are going to be breaking with the Population Health and Wellbeing series for the months of June and July. And we will be coming back to you, inshallah, starting again in August. And stay tuned for another series in the fall of all exciting sessions coming up. Dr. Mamtani, any last thoughts?
No, just I want to express my gratitude to Dr. Adeel Bhatt. A phenomenal discussion, a lot of interaction between participants and Dr. Adeel Bhatt. And so our sincere gratitude to you on behalf of IPH and Cornell in Qatar. And also, I'm also grateful to all the participants to have participated and asked questions and or made comments. So Ramadan Kareem and happy Eid in advance, and enjoy your days ahead. Thank you so much. Shukran.
Thank you.